Ezra.
Right, esteemed members, good evening, and thank you for joining us today. And just before we start, I'd like to encourage you to subscribe to the event on the PPB portal. You can use the keyword acute pain management, and you should be able to find the event easily. Kindly just take a minute of your time, go to the PPB portal and subscribe to the event on the keyword is acute pain management. The full name of the event is acute pain management in the community settings. All right, good evening once again, esteemed members, and welcome to today's webinar. We're very glad to have you joining us, and I see we have a good number that have already joined us on time. So for today's webinar, we have Square Pharmaceuticals, which is the sponsor, and this is courtesy of the upcoming conference. and we'll be having Square as one of the sponsors. And one of the things that they'll be giving us this conference is the polo shirts. And so that's an encouragement to everyone. If you've not registered for the conference, kindly ensure that you do so. We'll be having polo shirts that will be provided courtesy of Square Pharmaceuticals. So for today's webinar, we have our very own Dr. Andrew Kiko, who's a clinical pharmacist, and he'll be giving a talk on acute pain management in the community settings. And just a few reminders before we get started. This event is CPD accredited, and it's already available on the Pharmacy and Poisons Board portal. And you can use the keyword acute pain management to be able to access it easily. Remember, the sooner you subscribe to the event on the portal, the sooner we'll be able to share the CPD points with you. A few reminders to add. During the entire course of this webinar, you'll be muted. So if you have any questions, kindly use the Q&A tab and not the chat section, because it's much easier for us to trace the questions on the Q&A tab. And in the end, the speaker is going to address all the questions. This session is being recorded and will be made available on PSK's YouTube page, just for your reference. So at this point, I'd like to welcome our speaker, and then later on we'll be having the Square team. I see we have Dr. Rinton, Shajan, McKenna, who've joined us from Square Pharmaceuticals, and they'll be able to say something in the end, just before we close the session. So at this point, I'd like to welcome Dr. Andrew Kiko. Dr. Andrew, if you can hear me?
Yes, I can hear you. Thank you, Ezra.
Hey, thank you.
Let me just share my presentation. Just let me know if you can see it. Huh?
Yes, we can see.
Okay, that's fine. Good evening, members. Thank you for this opportunity. Thank you for the Square team also for making possible this webinar. So for the next, say, half an hour, 40 minutes or so, I think I'll take you through the topic, acute pain management in the community settings. It should be a fairly simple presentation, but I hope we'll have some learning points. Let me just see if it's moving. Hezron, from your end, I don't know. Yeah, okay, that's
yes, it's okay.
Yeah, so our learning objectives today will be quite simple. First, you have to define acute pain and take a look at examples of the syndromes that usually present at the community setups, especially at the pharmaceutical level. Then we'll recognize the importance. Why should we as pharmacists try and treat the pain where possible, and how will you evaluate and possibly have a differential diagnosis in mind? Then we need to understand a bit on the benefits of pain management to patients, and if there are risks or sort of red flags during pain management. Then we'll conclude with targeted pain management options, pharmacologic options for the different types of pain that are in the market. So let's look at pain. I think in the last few webinars we've had on pain management this year, pain has been sort of spoken about for a long time. So we want to zero in on, as pharmacists, especially at the community level, what role do we have? So when the definitions, especially because of when you look at the clinical definitions and looking at the International Association for Study of Pain, yes, pain has been studied. So this is an unpleasant sensory or emotional experience normally associated with some sort of tissue damage. So when there's a tissue damage, of course, the sensory nerves will send a pain sensation to the brain, and this will be interpreted, now as pain in sort of that definition. So it is varied when you look at it. So basically, pain management is a medical care that is being provided to those patients who need alleviation of this pain. Yeah. So we need to understand pain to the level that we can improve lives of our patients, especially at the healthcare setting. Wherever you are as a pharmacist, whether it's in a hospital or in a community pharmacist, we find that community pharmacies are usually the first stop point of care for many patients. So the kind of pain varies from acute to chronic. So there's usually at some point as a pharmacist, you'll handle pain, as you say. So I'll want us to keep these cases in mind during this presentation. So just walk with me as I define, as I put about 5 cases to you. These cases have different sort of pain with these patients. So let's look at one. There's an elderly patient who comes to the pharmacy because the bystanders found them in a road traffic accident. So there's the driver who was driving the motorcycle, and then there's a patient who was involved in the same accident. But let's look at these 2 patients. The driver comes in, is so calm, he's collected, he just says it's mild pain. But he was the driver, he's severely injured, but he just said it's calm. I mean, he's very calm, he's not collected. Well, the lady has been brought by probably a taxi to the pharmacy. She's throwing a tantrum. She's saying, I'm having pain all over my body. I need medication before I go to hospital. I need to relieve this pain. So look at these 2 patients. We'll consider them at the end. Then there is a baby who's been brought with an auntie or maybe a house help or probably somebody who's brought the baby. Keep in mind, this is not the parents who's brought the baby to the pharmacy, that the right arm, the baby is not using it very well as normal, is complaining of pain. And when you try to touch the child's arm, it pulls away. Yeah. But you could look at it, there is no swelling or deformity. So let's consider these 2 scenarios. Let me also have a different type of pain. So there's a lady, a young girl, who comes to the pharmacy and she's really holding her head. She said, my headache has been worsening despite I've been taking some headache medicine, and I'm struggling to open my eyes in bright room, and I feel like I want to vomit. So these are different kind of pain that we'll manage today, which comes to the pharmacy. Then, of course, there are places where you find sicklers. Sicklers usually have very severe pain. So they usually come and they say it's very severe, but there are no chills, no fevers, but they say the pain is worsening and these medicines are not working. And these are cases that you come to the pharmacy. Then, of course, we will not miss a toothache. There's always patients who are coming to go, to say, oh, my jaw, it's really acute. They're always holding their cheek and they're saying, oh, it's very painful. I don't have time right now to see the dentist. Give me anything that can just calm this pain so that I can see my dentist when I'm able to. Yeah. Then the other most common complaint that comes to the pharmacy, especially the elderly patients, is lower back pain. Yeah. So lower back pain is a problem that usually comes, and people use Brufen, all those types of painkillers. And what are the best drugs that you can give in this acute pain? And it's usually quite debilitating. Yeah. So we've already defined acute pain, but we see that one of the biggest reasons for patients seeking care is pain, one pain or the other. So 80 to 90% of the clinic visits or pharmacy visits, patients usually come or they're in pain, or they have some sinus headache, or they have some sort of pain, abdominal pain. It will always be one of the leading symptoms that brings the patients to the pharmacy. Yeah. So keep in mind that all pain is not equal. Even when you look at those cases that we have just shared, all pain is not equal. They all vary in different degrees. Yeah. So all those syndromes need different multimodal approach. So what you're saying, we'll understand it in the next few slides. Yeah. So acute pain particularly is a pain that lasts less than, that sort of began in the last 3 months or so. Yeah. or it can even begin in the last 1 week. It's acute. It means that it was not there, but it is actually one of the physiological conditions that has just risen, that is abnormal in your body, in your everyday life. Yeah. So most of the abnormal injuries are usually can be either post-operative. When you look at it, there's probably somebody went to surgery, was discharged, came home, then there's pain, or there's a fracture, something happened. We need to distinguish whether there's appendicitis. You need to know the kind of pain that is appendicitis. Then if it's a simple soft tissue injury. But the idea is in the last few months, not more than 12 weeks, 3 weeks, 3 months at most, yeah? So as a pharmacist, we need to set goals of care in acute pain. Our goal, obviously, should be to bring pain to a mutually agreed, tolerable level for the patient to do his or her daily life. So we need to bring that pain to a level where the patient can continue her everyday life. Yeah. We also need to understand that we cannot totally eliminate the pain. Sometimes it's not possible. Sometimes the pain is, is severe, and we need to find ways in which to help the patient through that process of managing pain. Yeah. Then we need to educate these patients. We need to tell them this is the kind of pain that is happening. It will still come and go, but now we'll give you some painkillers which will manage it, and you need to have a diagnosis probably with your practitioner. So pain must be rapidly and effectively treated if possible. So the reason is that you need to avoid what is called post-traumatic stress disorder. I'm sure all of us have seen these PTSDs in severe pain, in cancer patients, in soldiers, in post-op patients. There's always that PTSD that comes with the pain, especially severe pain. Yeah. And severe pain can even lead to psychosis at some point. I mean, we all know where pain can take you. Yeah. So undertreated pain can become chronic, and it means that the brain starts to adjust to that pain. So that is what is calling the neuroplasticity. So we don't want to go there. We need to manage this pain early so that you can quickly get to the diagnosis, so that the patient can explain themselves better. They can now, sort of get clarity on what is happening to their pain. So globally or internationally, there are about 5 steps which have been agreed, which are easier for everybody to sort of approach acute pain in patients. And we'll start with the first step. So the first step is history taking. How do you talk to the patient to understand what is happening? Yeah. So there are very many mnemonics that patients use. Yeah. But this is, I think, what I've been saying in the many webinars happening, and I think it's a good one. So from pharmacists, sort of start asking your questions to the patients. So the first, it's a PQRS sort of mnemonic that you can easily sort of ask the patient. When did the pain start? Yeah. Did it just start? Have you been having it for the last 1 year? Was there a trigger factor that helped it start? So you need to define when it started. Then what makes it worse, or what makes it better? When I sit down, when I lie, when I walk, those are questions that helps you now get a clear picture of what kind of pain the patient is. Then now ask how is the pain? Is it a sharp needle pricking pain, or is it dull pain? Comes and goes, it stays there, but it's a painful and it's affecting my everyday walk. I can't sit, I can't concentrate. Or it's crushing pain, like when patients come with a sort of heart attack, they tell there's a whole brick on my chest, it's crushing me. So you need to sort of analyze this pain as it's coming. Then come down to region. Where is it? Is it just regional? It's just on my knee, and the patient just say, no, just here at this point on the back. So going, it's just there. Or is it comes from the back, it goes to my thigh, even it's also on my ribs, those are, it helps you make a diagnosis. You can tell whether it's an infection or it's an injury, those things it helps you make. Then the severity of pain. Is it mild? Is it just moderate? Or it's severe pain, so that you know how to tackle it now, how to approach it, a treatment for it. And then timing, does it just come when you're walking, or is it just intermittent? Sometimes it comes and it goes, or it's constant, it's always there every time until it's brought me to the hospital. And then what are the associated symptoms? Yeah, do you feel weak? Do you vomit? Those are associated symptoms that come with it. Yeah. So you need to know when to, how to approach. Once you've established that small history, now identify, you as a pharmacist now look at, you're starting to develop a sort of diagnosis or maybe a classification of that pain. In the last few presentations, we've had classification of pain: visceral, neuropathic, somatic. So depending on how you've gotten your history, you're sort of starting to have classes for that kind of pain, what is happening. And then ask the patient, what have you been taking? What is your medication that you've been taking? Were you given some medicine post-operatively? Is it that they are over, or have you changed anything in your dosing? What have you tried again? Have you changed something? Did you change and go herbal and stop your painkiller? Those things that can help you make a decision on the way forward. So let's classify that pain, as you said. Yeah, let me just go this. So when you look at those first few questions, you'll have developed, a cause of the pain. So nociceptive basically means that there was an injury. Maybe there was a cut or something that hit on the skin. So that is why it's nociceptive. Inflammatory pain is like when patients usually say, it's pain on my knees, like arthritic pain. It's of inflammatory origin. So you already tell those kind of bone pain that are coming in. Then neuropathic pain, those sharp pain that comes in, it feels like it's burning. Those are things. Then psychogenic pain, it's mental. You'll always just listen to the story, then this is psychogenic. There's a source from somewhere. Yeah. And then somatic and visceral. So anatomic. Now you'll need to know where is this pain coming from. Now you can develop a pathway. Yeah. Then classify it. Is it acute or chronic, or is it acute on chronic? So acute and chronic, we've been defining on the last few webinars. Acute and chronic is probably straightforward. Somebody who's had a chronic back pain, then suddenly it's worsened in the last 2 weeks. So that's an acute pain on chronic pain, yeah? Then intensity is very straightforward. Mild, moderate, severe. You'll just tell. Then we as pharmacists, sometimes we don't get the chance to physically examine our patients, probably because of the time, the pressures of work. But you can easily just look at the patient. If it's a baby or an adult, you can have a look at facial expressions. You can see somebody who's in pain, probably crying, or his eyes are red or her eyes are red. Body posture is walking funnily because of the part that is affected. You can look at it. Or the skin are flashing, they're sweating. You can always tell somebody from facial expression. If it's a kid who's crying, who's rinsing, who's throwing their arms and legs, they just want to hold their mom, you can always tell like a kid who's in pain. Yeah, because anyway, when you're in pain, your pressures will go up, your heart rate will be very fast. Those things. Yeah, so pain is an important symptom for management. Yeah. We're probably in a clinic, some patients are very smart, they can come with some labs that have been done or tests, trials that has been done. Then you can help you make a choice on treatment. Yeah. Then we look at the red flags. Yeah. So as a pharmacist, we probably have to identify those red flags that worry you when your patient has come to the pharmacy for some pain. So look at what we mean by neurological deficit is a confused patient. Does it look stable? You can always see their slurred speech and they're not cohesive. So those things should worry you. They're saying they have headache, but they take a long time to explain their symptoms. It's like they're gazing somewhere. Then that tells you, there's something serious that is happening. So those are referral cases. You don't want to quickly get into it. Those are patients you need to refer to a specialist for management. Vascular abnormalities, there's excessive bleeding somewhere. You can look at the skin, there are things that you can see they're off. They point you to an emergency case. So those things are easier to refer. Then those patients who have high fevers and they look sort of wasted, they look a bit malnourished, they look weaker. So it tells you that there's an underlying chronic condition. So you don't want to quickly intervene until they've been fully diagnosed. Yeah. Then the fourth step is, of course, intensity. You can use the facial expression scale or the WHO, this pain rating scale. Yeah. So you can quickly ask out of 10, just rate your pain. Some patients, depending on your assessment, you can know whether the patient is anxious or it's true pain. Yeah. So those are the intuitive skills that you need to have as you look at this patient. So that patient is really 14 out of 10, I mean, severe pain, but when you look at them, you can quickly say, it's probably they're just being anxious. Yeah. So there are very many skills you can use. I don't think I want to enumerate on these skills. Then we look at now treatment. Yeah. So when you're looking at acute pain from a pharmacy point of level, once you've understood now the origin of this pain, we are lucky at least we know all the pain medications that are in our pharmacy. You can look at the combinations, you know some of the common side effects and the new pain medications. So you can make a choice of easier over-the-counter pain medications that can alleviate pain for the patient. So, but the best way is to looking at our cases. First, we've sub-classified. There are traumatic injuries. So like the first case I told you of the patients who were in a road traffic accident. Then there are headaches. Headaches are vast. There are very many different types of headaches. So how do you treat those? And among the most common is low back pain. So low back pain is vast as well. I mean, you need to just know your red flags on low back pain. Yeah. Then dental pain, it can be acute and debilitating. I mean, patients won't sleep the whole night and they'll come to you. Sickle cell are also very severe crises, especially when they have the attack for the pain that comes during a crisis, a sickle cell crisis. So these are all emergencies. Abdominal pains, patients usually walk into the pharmacy, they're holding their tummy, you can see that. So you need to know, what are the danger signs for this abdominal pain or renal colic pains, yeah? So if you look at traumatic injuries, these are very common. There be contusions or concussions or sprains or lacerations or fractures or burns or others. These are severe pains when you look at it. I mean, it can be a baby to a pregnant mother to an adult. All these are severe pains, yeah? So these are pains that, as from a pharmacy point of view, somebody comes to you, even from just visual, you can tell that this is severe pain. So you won't just quickly just give simple analgesics like paracetamol. You probably want to give a much higher NSAID or something like that, and they refer them to the hospital where they can get now much stronger analgesics. So at the hospital level, at the pharmacy level, let me just go back here. Sorry. At the pharmacy level here, we are looking at quick-acting analgesics. I mean, you can look for diclofenac sodium or some quick-acting analgesics so that you can calm the patient so that they can quickly go for treatment. So at the casualty level, A&E levels, such kind of patients, because they're in severe pain, they're the ones that usually go for short-acting opiates, start doses, or nowadays at least we have an IV paracetamol that is commonly given in the casualties. So most guidelines start with IV paracetamol. Then they can, if it's not the pain is not very well controlled, then they can go for the opiate short-acting. So they can give morphine. Morphine is the most common that they give start dose for acute traumatic pain, so that now you can manage the patient. So and it's the good thing, morphine also calms the patient indirectly, so you get an advantage to assess the patient and treat. Yeah. Other things that are done in the hospitals now to decrease the pain, now looking at the trauma, is dressing the wound, splinting it if there's a fracture, so that the patient can be seen now by a specialist. Yeah. Regional blocks are usually very common in orthopedic surgeries. Yeah. And spinal blocks, mainly we see it in theater for serious cases. These others, then sometimes we try and, where possible, distract the patient, non-pharmacological methods, so that you don't give too much or higher dose of medications unnecessarily. Yeah. Then you look at headaches. Yeah. So headaches are they account for more. I think so studies are showing 2 to 4%, but I think it's higher, probably 10% of casualty patients who come in, they have that headache as a symptom. And headaches, it's good to agree that it's good to differentiate life-threatening headaches from just normal benign primary headaches. So the patients who come in holding their head, and you can look at them, they are adult patients who are holding their head, it can tell you this is early signs of a stroke, So you need to also have that intuition sign to recognize some life-threatening headaches, which can lead to some fatal outcomes. Especially these stroke patients, like now we're getting very many younger patients who are getting affected by stroke, and it's a worry what's happening in the society. Then the ones who come with a headache that has a sign of meningeal irritation, stiff neck, and then you look at them, they have severe headaches. You should always tell you meningitis is there, some irritation somewhere, so you need to know when to refer them to specialists for management. Yeah. I think I've said this. So these are the two categories of headaches, primary and secondary. So primary can be easily managed, simple tension, migraines, cluster. You need to just differentiate your headache, then now zero in on the targeted treatment for these headaches. Secondary headaches, those are telltale signs that something is happening that is very serious to this patient. So those are patients you probably need to quickly refer, where you can tell them, no, this you need to urgently see a specialist and go to the nearest clinic next to you. Yeah. So when you look at migraine headaches, all these headaches are managed differently. Migraine starts slowly, mildly, then progressively increases. Sometimes it's usually one-sided. That's what patients say. Then it has nausea or vomiting and sensitivity to light and sound. So once you have that small history, you already know. In fact, currently most migraine patients, unless those are new diagnoses, but most of them will already know what triggers their migraine. So the Headache Society says currently aspirin is one of the key drugs for migraine management. Yeah. And then these others are additives. So it depends on diagnosis. It depends on many symptoms. Triptans are usually now one of the early drugs of choice for treatment for migraines. Migraines with some aura, you need to know how to calm the patient with medication, ask them to sit in a quiet room, a dark room, so that while the symptoms are alleviated with the drugs. Yeah. Opiates are not one of the best drugs of choice for migraines because some studies say it tends to make the migraines chronic. Yeah, so you say, in a sense, it says that patients who used opiates in the first instance of a diagnosis, they tend to have recurrent migraines down the road. Yeah, so it's easier to have targeted therapy for migraines vis-a-vis quickly starting the opiates in migraine patients. Then cluster headache, it's all over. I'm not too sure what's happening in my head. So it's just happening. They tend to hold their forehead around the nose. They just tell you, just around my face here, something is happening. So among the symptoms that come there, most likely the sinus headache, rhinorrhea, and they can be associated with some tearing, squinting of the eye, or the eyes are really, they seem like they've gone in, there's subtosis in the eye. So especially when you start seeing those, the eyes seem like they become smaller, you need to start thinking what's happening. Is there an underlying chronic condition that is happening? Yeah, those are symptoms. So you need to know what are the red flags at that point. Treatment for these cluster headaches, mostly it's minor. It depends. Some steroids can be given. Gabapentin has become a drug of choice for that, but it's not very commonly given. So people tend to try and start first with paracetamol and see how the progress of this is. Then improve the breathing in the nostrils, where there's no need for really oxygen supplementation unless it's a worse of case. But once you've opened the airways and we've allowed the mucus to come out, I mean, most headaches usually tend to become alleviated. Then tension type headache, the one that they say that there's a band on my head, what is happening? Yeah. So usually these are tension, stress related. There are gays who've been thinking too much, there's a tension, there's something, they're on a tight schedule, they want to finish work, so there's tension, yeah. So those ones sometimes necessarily don't need treatment. You can start non-pharmacological treatment, calming them, put just a cold, a wet cloth on the forehead. It tends to calm them, yeah. Where necessary, then you can go for simple analgesic, probably paracetamols, yeah. Worse off, you can go to NSAIDs, but paracetamols will tend to relax this type of headache, yeah. So these are just simple non-pharmacological methods. Headache is also associated with alcohol use, with weather changes, with diet, with stress, and some hormonal changes. So patients tend to know themselves. You can know there's a hangover, there's a chronic alcohol use. So also this is part of us to educate them on, these are the risky factors for headaches, yeah. Then the commonest symptom, lower back pain. 85% of adults will have lower back pain at some point in their lives, yeah. I mean, especially once you're above the age of 35, 40, at some point you start having those lower back pain in their life. I'm not too sure that it's the stress of work. It affects both men and women, actually. People say it's a lot more common in women, but lately even the men are having this lower back pain. And it sort of tends to become chronic at some point, yeah? So for lower back pain, what as a pharmacist, I think what I probably could say is that from theory, what we say is that we need to recognize that lower back pain is a symptom for so many diagnoses. It can be a simple strain, it can be a cancer, it can be a METS, spread of cancer to the spine. It can be infection related. In fact, we see quite a lot of patients with TB having a history of lower back pain. Yeah, it can be an abscess, especially where you see that they tell you, my backbone seems there's something that is swollen around on my spine, something is off. Then you touch it, it's quite soft. You find this looks like an abscess, so let it be investigated. It can be a hematoma, it can be slip discs. Yeah, so those are things you just have to be at the back of your mind. You have to have those diagnoses at the back of your mind, so that you need to, that should point you, tell them, no, first go see this orthopedic specialist, that you'll be evaluated, let him do an x-ray so that you get to know what's happening as you manage that pain, yeah? And then look at also the socio-physiological factors. What else is happening surrounding this patient? Is he an obese patient? Is he an elderly patient? The female genders usually, especially at elderly female, have these lower back pain issues. So is it hormonal related? Is it calcium related? No, those things you need to work out to get your diagnosis, get a proper history from that patient, yeah? And then psychological factors, is there a stressful job? Is the patient satisfied at work? So lower back pain is a symptom of much greater things. Is it a psychological issue, depression, anxiety? Those are things that you need to look out for, yeah? Then now the three things when you need to know as a pharmacist is there evidence of a systemic disease? If somebody says lower back pain, ask, is there, maybe can be a UTI. If it's a lady, is there evidence of burning sensation or change in urine patterns or something happening? If it's a chronic patient who comes to you for pain management for lower back, do you think there was associated fever, or does the patient look a bit wasted? You need to make a decision so that now, besides just giving you painkillers, I think we need to understand what's happening. And then, is there an evidence of neurological compromise? Meaning, is an evidence CNS over CNS infection. The spine is usually the number one factor to show you whether there is problem meningitis. You need to make a decision, look at it, and you need to refer this patient to a physician for full diagnosis. Yeah, and then is there psychosocial distress? You can easily tell a patient who talks a lot, who speaks, who's remonstrating a lot. So you need to calm them down, then ask them what's happening in your life. Slowly you can quickly reach. Once you've answered these three questions, especially in the lower back pain, then you can quickly know what to do moving forward. If all this is no, then you can give a simple painkiller, then ask them to come back for review. But the red flags, as I've said, if there's a history of malignancy, was there been treated before for cancer or something like that? What have you been treated before? You don't need to tell patients it's cancer, but just ask them, have you been treated for this condition before? What have you been treated before in the hospital? Then they'll quickly say. Neurological deficits, it's you to make that decision and see. Then is there fever, weight loss? Those are things that you probably just even look at the patient and get to know. Elderly and much younger patients, for the elderly, it's more common for them to ask these questions, to present with these symptoms, as opposed to the younger patient. The younger patients, if they come with a lower back pain, it's something you need to be, cautious what's really happening, especially teenagers coming with their back pain. It needs investigation. Yeah. Then pain that worsens at rest, that's also a danger sign. Is it DVT happening at some point? So you need to know. Yeah. And then, of course, immunocompromised patients. Those are patients you need to be very cautious, especially in our setup, HIV patients. Is there chaos happening somewhere that you don't see? Those things. Any history of a recent infection. Those are things that you need to know. In terms of treatment, most people tend to use NSAIDs, but of course, cautiously. You need to know which NSAIDs to choose, which have at least COX-2 inhibitors are one of the safest to use. Just choose a crossboard depending on the social status of the patient or where possible, and something that is affordable at the pharmacy, or you can see which patients can afford which drugs. Yeah, so you can choose NSAIDs. They're very good, especially for the younger populations, because their vitals and organs are quite stable, so they not experience most of these side effects of NSAIDs. Then paracetamol is for patients who cannot tolerate NSAIDs. Yeah, paracetamol is a baseline, really. Yeah. Nowadays we have paracetamol with the muscle relaxant, so you can tend to use those combinations so that you alleviate the pain, you make the pain more comfortable. Then opioid use is mainly for those chronic patients, especially the ones who've had several spinal surgeries. They tend to be on these opiates, for long. Yeah, and for acute conditions, some steroids are used, especially for spinal injuries. Yeah. So non-pharmacological, what we can tell patients is that exercises, those are things that you can do. They can try chiropractor. Chiropractor can try and alleviate the pain. Yeah. And physiotherapy is physiotherapy, yoga, meditation, acupuncture, all efforts to alleviate lower back pain. Yeah. So the Americans are actually recommending this, so which is something that we should embrace. There are very many chiropractors in the society. I mean, they really help, especially the elderly, when it comes to especially for lower back pain. Yeah. So chronic pain, I'll just touch a bit. First line therapy, NSAID. Second line, you can go to safer opiates, non-opiates, really, tramadol, the likes. Yeah, they can really help on those acute pains. Yeah, opiates. And the last line, once you really have failed the first line and second line. So opiates, at least you need to know how to use opiates and for breakthrough pain. Dental pain. The challenges that we have in dental is that most Kenyans don't have dental insurance, and they tend to come when there are cavities, there is an abscess, and the pain is affecting the whole head, is going to the neck, and that's what the common symptom usually patients say. And dental visits are not cheap. Yeah, so patients tend to take advantage at some point. They just want a delay. So it can be because of an abscess or something like that. And then there'll be a swelling. It's sharp, throbbing, and constant pain. Yeah. So still, NSAIDs come in as the drugs of choice. You can look through and then know when to refer these patients to the dentist anytime. Sickle cell, we have very many patients now, millions of patients in sickle cell globally. In Kenya, I think there are less than 50,000, but they're there. So sickle cell is a disorder that comes in, and the pain is because of this circulation is obstructed because of the red blood cells. Yeah, and once you assess that pain, like I said before, the drugs of choice tend to be quite strong drugs. So those are patients you tend to refer to the hospital to try and, for acute pain, they can be given opiates as a start dose, and then they can be managed case by case with NSAIDs or paracetamol at some point. Yeah. So NSAIDs, you remember the safety profile in sickle cell patients. So you use them sporadically where patients can tolerate the NSAID. And of course, then they use non-pharm. Yeah. Then always remember the opiate side effects, sedation, constipation. So always know that the patients will present with this. So as the patients are given this, always remind your clinicians also to cover for the side effects. Abdominal pain, very common. They'll always come. And you'll always, just what you need to know is the risk factors for abdominal pain, yeah? So always know these diagnoses are the ones that you don't want to miss. Appendicitis is very classic, you'll know, and it's regional, especially on the left side, on the left lower abdomen, yeah? You'll tend to see it. Diverticulitis are very common. Gallstones, abscesses, perforated ulcers, patients who are even vomiting blood and severe acidity, pancreatitis, a ruptured ovarian cyst, ectopic pregnancy. Those are symptoms you don't want to miss. These are emergencies that you have to refer these patients. You don't want to have an emergency in your pharmacy. So these are things that you want to advise these patients. Once you look at their history, ask them to quickly rush to the hospital. Yeah, for abdominal pain, lately we have hyoscine that people try to use for it. Paracetamol still works across board. Severe pain goes to morphine. Then you do the normal lab checks. Yeah. For kidney stones, which are also very sharp pains around the groin or the backside of your backside, you tend to see those renal colic pains. So they can be associated with all these other symptoms that you see there. But these are the risk factors that come in: dehydration, the uretic use. Pregnancy is also a risk factor, or recent surgery, or medicine. Yeah. So treatment is more fluid hydration, a bit of pain management, and nausea, like ondansetron medication, so that you manage this patient as you wait for Sometimes with proper hydration, the kidney stones will come out. If not, then they can refer them to urologist or nephrologist, so they can try this and the new challenges. So newer methods that have been used in developed countries is an attempt to use the intranasal route or nebulizing route for opiate administration. It hasn't reached here yet. I don't know whether there are hospitals that are doing this, but these are newer and quickly they actually relieve pain. So we are hoping to get into to get these new therapies in the country. So I think I've tried to manage these cases. So I don't think I'll want to overemphasize. So these are my summary learning points as I finish. This is probably my last line. The optimal method for treating a patient's pain, it depends really upon the type and the origin of pain. And if possible, if you can make a diagnosis, that makes it easier for you to choose a pharmacological treatment option. So manage the pain while having a definitive diagnosis, or while you're seeking a definitive diagnosis, so that it eliminates and always have the red flags in mind. Yeah, those are the summary points. Then there are many options for treating acute pain, from opiates to NSAID to varied consider all your options, look at the patient that you're treating. It's not a one case that fits all, but you need to have a wholesome approach to pain management. Yeah. So be on the lookout for those they can't miss the red flags, be aware of side effects, and then know the law, especially for the drugs, especially as pharmacists. There are controlled drugs, there are laws of the country that take place, so you know where your limitations as a pharmacist. Yeah. So thank you. Back to you, Hezron, and I appreciate for the time and for you guys to listen. Let's all unite against this pain. Thank you.
All right. Thank you so much, Dr. Kiko, for that insightful presentation. And I think because of time, we'll quickly move to McKenna, who is going to present on behalf of Square Pharmaceuticals. And then thereafter, we'll have the Q&A.
Good evening.
Good evening, Karibu.
Okay, sawa,
Yeah.
sawa.
Can maybe
So
have the slides
slideshow.
on full screen? Yeah.
Okay. It's on slideshow now, right?
Very
good, yes.
Yes, so I appreciate everyone for making time to come for this presentation. So my name is Evelyn McKenna, and I'm here to represent Square Pharmaceuticals. Square Pharmaceuticals is the first multinational company from Bangladesh that has been the market leader in Bangladesh since 1985. Now, when we talk about self-sufficiency in pharmaceutical production, in Bangladesh, 44 years ago, the multinationals had the bigger cake of up to 75%, but this situation has changed. As of 2023, 92% is dominated by the local manufacturers. That's also where we want to go as Kenya. Now, Square started as a small pharmaceutical venture in 1958, and it has 27 different companies in one: healthcare, textile, FMCG, IT, media, and agro-processing. But we are here today because of healthcare and pharmaceuticals. In 2023, is a $2 billion US company. Presence, global markets, we are present in 45 countries, and 13 of those countries are in Africa. We have 15 different manufacturing sites in Bangladesh, including insulin and metered-dose inhalers. And most of these manufacturing sites are approved by the major regulatory, the key regulatory bodies. I'll just take you through briefly the manufacturing plants that we have in Bangladesh before we come to our Kenyan plant. So this is where it all started in 1958, our general production unit. The plant is supplying 3 billion tablets and capsules, 25 million tubes, cream ointments, and 146 million bottles of liquid and 47 million ampoules of injection per year. We also have our penicillin unit here with a capacity of supplying up to 300 million tablets, capsules, and 13 million powder for suspension. Then we have our general solid dosage unit that has been approved by all these regulatory bodies. This is just to show you the pictures or the images of our plant. Also the cephalosporin unit, approved by the regulatory bodies, as I have mentioned. And last ophthalmic unit also, and the insulin unit. Now back to Kenya. This is the 3D model of our plant at EPZ. It has 3 key demarcations. We have the tablets, which is operational as at now since 2022. We have the injectable side and also the solutions side. So this is the outlook of Square Pharmaceuticals, EPZ Kenya. We are built in a 17-acre land at EPZ. Still on the outlook, this is how it looks. For those of you who will be lucky, we are open. We can take you to see our plant so that you can see it for yourself. Now, we have state-of-the-art machines at the plant and a well-equipped QC lab. I want us to look at this video, just a short video that we can listen to.
Ken, it doesn't have the sound.
All right, let me just check on it.
McKenna, maybe you can check when sharing the video, there's a place where you can check a box that says share with sound. Just when you're sharing your screen, you can stop the share, then share again.
Wait, all right.
If it's not working, you can go to the products.
All right. Okay. Sorry for that each. Today we were looking at pain management. So I'll dive into our pain management portfolio. We have 3 molecules for pain management as COYA, and all of them start with T. Our lucky number is T. So we start with Tori. Tori is our brand of etoricoxib. It comes in strengths of Tori 60, Tori 90, and Tori 120 mg. And the punchline is killer of all pains because it's able to take care of all kinds of pains. Now, which are the 3 key strengths of Tori? Tori effectively treats pain within the first 24 minutes. So when that patient walks in, maybe to the pharmacy in the hospital or just at the pharmacies in CBD or other places, your patient will be free of pain as fast as possible. It has a better safety profile in that it's selective in patients with gastrointestinal disorders as compared to the non-selective NSAIDs, e.g. diclofenac, dexkitoprofen, and the rest. It ensures patients convenience with once daily dosage. Nowadays, you find patients, maybe this patient is diabetic, they have hypertension, so they have other drugs that they are taking. So once daily dosage ensures compliance for this kind of a patient. So Tori, either 60, 90, or 120 is able to take care of the patient for 24 hours, as we can see on this clock. Once daily dosage in all indications. This is the presentation of Tori, 60, 90, and 120. It's well available in the pharmacies, even in some of the mission hospitals, because it's also listed for those pharmacists who are attached to mission hospitals. you can ask for Tori by brand from Meds. Secondly, we have our second brand for post-operative pain management. In major surgeries where safety is a great concern, you need something that works very fast. So for management of post-operative pain, opioid analgesics are usually the first line. But these opioid analgesics have some serious side effects, e.g., like Dr. Rocco said, respiratory depression, addiction and dependency, euphoria, interference with bowel or bladder function. We have Torax, which is our ketorolac brand that comes in presentations of a tablet and injectable with the same efficacy as the opioids, but without the side effects. So Torax or ketorolac is namesake that falls in the class of pyrrole acetic derivatives, a very good analgesic and anti-inflammatory. So ketorolac also has a better cardiovascular safety when you compare it to the other NSAIDs. That's the reason even it was adopted in the essential drug list in Kenya. You'll find that most of even KEMSA has ketorolac as a molecule. Secondly, Torax injection is versatile in that you can give it either IM or IV. Now, it's indicated for short-term management of moderate to severe acute postoperative pain. That's one of the indications, but even other indications like dysmenorrhea, the acute episodes of osteoarthritis, musculoskeletal pain, you can still use Torax for these kinds of pains. Now, we have our third product for management of pain called Trampa. And in mild to severe pain, we have a new era in pain management. Multimodal analgesia is key. Now, multimodal analgesia is a pharmacological method of pain management which combines two medications. The WHO analgesic ladder for moderate to severe pain recommends use of a combination therapy of opioid, a strong opioid and an opioid. And a strong opioid and an opioid, as I've mentioned earlier. Paracetamol is the most commonly accepted non-opioid medicine, which significantly improves the quality of analgesia when combined with opioids. And tramadol is the most common opioid drug used for moderate to severe pain. So Square choose the best combination by the name Trampa. This is our combination of paracetamol 325 mg and tramadol hydrochloride, that's 7.5 by brand name Trampa. This is a product that we are making locally here in Kenya. I would say price is not the thing that we look at, but we also look at the efficacy. So with our state-of-the-art plant, we've given you the best, the most affordable tramadol paracetamol combination by the name Trampa. So we are selling it at 25 shillings per tablet. We've made efforts to make it available in the key hospitals, in the pharmacies, and also for your own pharmacies. Kindly look out for Trampa. Choose the ideal combination of paracetamol and tramadol. Now, that was on our pain portfolio. I'll just show us a slideshow of our pain management. We have Torax. Torax is ketorolac, injection and tablets. We have Tori, our killer of all pains. Then we have Trampa. Next, I will go to our other brands, our gastro products, which we are also making in our plant here. We have Protas, which is our esomeprazole. Our acronym is Protect Acid Secretion, comes as an injectable, 40 mg, Protas 20 and Protas 40, the on-demand PPI. Secondly, we have one of our newest babies, Pilotrip R. I know most of us have come across Pilotrip, but now this is the newest baby whereby we have rabeprazole instead of lansoprazole. Rabeprazole is more potent and it has a better acid control. So if you're keeping Pilotrip, also have Pilotrip R on your shelves. Then Acintamax is our alginate antacid that treats heartburn and indigestion simultaneously. These are sugar-free molecule. Even for the diabetic patients, you don't have to worry about them. Then it's a whole 200 ml value for money for your patient. The originator is 150 ml, which we are not going to mention here. So at only 468 shillings, your patient is able to be covered for more than a week. And the other thing about it, after opening the bottle, you can use it up to 6 months. So there's no saying that your money has been lost after managing your heartburn and indigestion. Thirdly, we have Nilasip. Nilasip is a combination of magnesium hydroxide and aluminum hydroxide. I would say the most homogeneous antacid that we have in the market. It's well stocked in the pharmacies. It's available in all distributors, including meds, and we have it in 2 volumes. We have a 200 ml and 100 ml in green and blue, respectively. Our other over-the-counter brands, we have our Ambroxol hydrochloride. That is also a very common one in the pharmacies. We have Osmolax. Osmolax is our lactulose. Osmolax is osmotic laxative. We have it in 100 ml and 200 ml. Then Flona spray, our Flona spray, nasal spray. Now, we also have diabetes management. We have three different molecules: empagliflozin, linagliptin 5 mg, that's 10.5 and 25.5. These in diabetic patients with comorbidities like CKD and hypertension, patients who have other comorbidities, you'll go for Glimpa either 10.5 or 25.5. Then we have Glitamet. Glitamet is our sitagliptin metformin, 50, 1,000, and 5,500 for first-line management of type 2 diabetes. Then Linita. Linita is our linagliptin for patients with CKD, and we call it end-stage renal disease. So this is our diabetes portfolio in a slideshow. These products, Glitamet, Glimpa, we are making them here in Kenya. So there's no time, like most of the companies will say, we've not been able to supply this brand. So once the patient is put on either Glimpa, Glitamet, Linita, we are sure that we are not going to go out of stock. We are making the 3 of them in Kenya, so they are available for your patients. Then our hypertensive portfolio, we have Telmiloc, that is our brand of Telmisartan, 40 mg, 80 mg, then Angiloc 50 and Angiloc Plus, that is first-line management of hypertension for the ARBs. Angiloc is also available in meds, is also available in all, I would say like most 90% of the hospitals have these molecules. Then Bisolol, this is our bisoprolol, 5 mg. The cool thing about our Bisolol is that it's scored. So if a patient, if a doctor prescribes a 2.5 or 1.25, it has a score line in that once you press, you're able to achieve even 2.5 for your patient. Thank you. I'll welcome questions. Elvin is going to take the questions.
All right, thank you so much, McKenna, for that presentation. And I think we'll now move to the questions, and then thereafter we'll have the closing remarks from the team. So I think I'll start with the first question, I think, which is addressed to Dr. Kiko. And there's one of our members who's given something like a case study here, who's saying TM is a 40-year-old patient who has undergone 3 to 4 surgeries repeated after 4 to 6 months of a failed femur fracture repair. What would be the best analgesic of choice when tramadol is not working at optimal doses?
Thank you, Ezra, for that question. I can see a few questions in the panel. Can I just tackle the
Yes.
directly when I finish those ones? Yeah.
Sure. That's okay.
Okay. So there is somebody, I think there's an anonymous attendee who added that we should add period pains in the monthly period pains in the presentation, especially at the abdominal pain section. Yes, I agree with you. These are among the common cases that come to the pharmacy. How do you manage period pains for patients? So period pains are gynecological issues. I mean, some can be physiological, sometimes they can be pathological. So as like an acute pain when a patient presents, simple NSAIDs or combined or even paracetamol tends to be the first line therapy for these. When it becomes, if you follow the WHO ladder and you find that the pain is severe and persistent every month, then it's about time. It gives you a red flag that that's a patient that you should refer to the gynae so that they can probably look at other options. Do they need, oral contraceptive, hormonal pills to manage the pain, or is there something else happening with the patient? So yes, I agree. Those are things that you should add and become red flags. Then we have somebody else who's asking, my slogan, no pain, no gain, in regards to our topic today. Yeah, what does this mean? So I know, I see where you're coming from, and I know, let's say like in athletics, they are told you should persevere the pain if you have to succeed. You have to run very hard, no matter the pain, for you to gain the gold medal. Yeah. But I think I use it here in a different perspective. In a sense, pain is an indicator that something is happening. Yeah. When there is no pain and there is something wrong with the patient, you're really at a limbo. You don't know how do we help this patient. But when somebody's saying the headache is, I'm feeling the headache on my forehead, the patient can quickly gain, you can, as a clinician, you can quickly get a diagnosis. You can focus on that patient. So when there is pain, it's protective sort of to the body, at least it helps even from a clinician point of view, tell you that something is wrong, this is where you should direct your efforts. So in regards to this presentation, I think this is the meaning that I'm trying to get by saying no pain, no gain. When there's pain, then when there's no pain, you don't gain, from a clinical point of view, you can be working, something can be happening. Let me give a small story. When, like Alzheimer's patients, when they don't really know what's happening, they're admitted, they can't even say that there's pain and they are probably in their hips or something, they fell down. It takes you a long time to discover that there was an injury. If they could have just simply told, they fell down and they're feeling pain, saying their hip, you'll have discovered and managed it earlier. But you tend to discover it later when there's an infection, there's sepsis, it has complicated. I don't know that it makes sense. Then there's somebody who said I was going too fast. Apologies. I think this is because of time. That's why I was trying to rush so that we can hit the target time. So on our patient for surgery who's undergone 4 surgeries, I don't know the type of, a failed femur surgery. So probably this is a hip replacement surgery. And so I'm assuming this is an elderly patient. So hip replacement surgeries are quite complex, and they can easily fail. So if you are to use a 4 or 5-step analysis for this patient, this is probably a patient that will, at risk, if we introduce opiates this early, is at risk of dependence, because once if the hip replacement surgery has failed, then your options are very limited. This is somebody who will have a very debilitating, painful sort of sequel. So the number one thing is go back to the surgeon. What can you do? How can they revise? Look at the surgery. What is the best way they can manage the surgical area so that it helps the patient to heal. Because now it's failed, what is the way forward? Can we rest the wound so that it heals, so that we alleviate the pain? If by the time your tramadol is not working, then your options are looking at opiates, yeah? But we can look at multimodal care. Let's start having different analgesics which work on different pathways. We see that they can manage the pain, yeah, while we plan for surgery, because you need to get an experienced surgeon to look at that wound, see what you can do to minimize the pain, to make the patient feel more comfortable. So this is a type of surgery where you need an experienced surgeon, I must say, somebody who will sort of clean that wound nicely and make it more comfortable for the patient here. Because by the time tramadol is not working, something is off, something is wrong. We need to look at the underlying condition. So this, you don't want to quickly, you can do short-term opiates, but while working at a surgery, a relieving surgery, I don't know if I can use the right word, a relieving surgery, so that you can live long-term without having chronic pain. Yeah. Then Dr. Kivoto is asking the best analgesics for pain for more than 50 years. I'm imagining you're asking for an elderly patient more than 50 years. So as I said, if it's acute pain, I think we are very straightforward on the drugs of choice. And I mean paracetamol and NSAIDs, safer NSAIDs for this patient. But if this pain is more than 3 months, then it becomes a chronic pain. Then you need to start asking yourself, what is happening for this lower back pain? Is it weight related? Is there an underlying condition? What is happening to patients? If a patient has taken drug for more than 3 months and there's not a quick relief, it keeps recurring, it's something that we need to investigate. Yeah, is there an infection? Is there a systemic issue? Those are things that we need to look at. Because with NSAIDs and paracetamol, routinely lower back pain should be well managed for those patients. And then also add and pharmacological interventions. Elderly patients benefit a lot from chiropractors here. I mean, visit chiropractors, let them try and look at the spine. Is there an issue? Yeah, so that they align the spine nicely. It usually relieves a lot of pain. With a sciatic nerve issue, then now we need to look at physiotherapy, what is happening here at that point. So probably these are things that you need to look at. At the same time, somebody has said you need a session on mental health and alcohol abuse by medical staff. I think that's for you, Hezron. You'll probably give an answer for that if there are sessions for that. Are NSAIDs safe during pregnancy when managing pain? So this is dependent on the stage the pregnancy is. Probably early, first trimester, you may not go for NSAIDs. And what kind of pain you'd be looking for probably in pregnancy? If it's traumatic pain, then yes, sometimes at that point you really have no choice. You have to quickly make a decision that the patient has to get a short-term dose of an NSAID, depending on the safer NSAIDs. Yeah. At the third trimester, then you really don't want to start using NSAIDs at the third trimester. Yeah. So third trimester, you need to probably just maintain one of the safest pain analgesics in pregnancy is just quick paracetamol. Yeah. So you don't want to introduce drugs that can have adverse effects in the birth process and on the baby. Yeah. So NSAIDs are during pregnancy, we try as much as possible to avoid unless very necessary. So during pregnancy, we just use paracetamol in managing pain, unless it's debilitating pain, which then we need to analyze what's happening. I mean, if it's an ectopic pregnancy, then you need to go straight and sort that ectopic pregnancy. You don't need to give painkillers for those. Let it be managed as an emergency in the hospital. Yeah. So during pregnancy, you have to be very careful on NSAID use. Yeah. Then I can see a question. Apart from opiates, in managing pain in oncology patients, which other drugs can you recommend due to addiction that comes from opiates? So there was a session for this, was it last month? We really don't need to be afraid of opiates, especially in oncology pain. The pain that oncology patients go through, I think we had a patient a couple of months ago who One of the sons was a clinician, and he was really anti-opiates, anti-morphine, yeah, and the patient was really suffering. Let's understand that addiction from morphine is very low on clinic use. Yeah, on abuse, yes, it can, then it becomes, but on clinic use, especially in oncology patients, it's well advisable. The earlier you start patients on opiate use, especially morphine syrup for breakthrough pain and for severe pain, the more comfortable the patients are, yeah, at an early step. So let them come to the clinic. They can be taken through advice on opiate use, especially like morphine. Especially for these oncology patients, the pain is severe. You know, if you look at the WHO scale, it's 14/10. So the pain is really, really severe. So they need these opiate, start using opiates as early as possible in the process of treatment. What is the relationship between pain and high blood pressure? This is sort of straightforward. When you're stressed, your pressures, your heart will start beating fast, and it's sort of like a protective mechanism that comes in. So that one is very straightforward, a response to pain, the body response to pain. Have I finished? Oh, there's one more. I think the last question. What if a patient has severe menstrual pains? You give tramadol and has some side effects as nausea and body weakness. Is it the effect of a drug, or it's due to menstrual issues in a 49-year-old patient? Who will you give tramadol for menstrual pains? I don't think it's the drug of choice. NSAIDs and pure paracetamol are the drug of choice. Tramadol, no. Tramadol is associated with nausea. So most of the time, if tramadol is given, there should be metoclopramide or ondansetron. So ideally, this will not be the drug of choice for menstrual. Unless these severe pains, you need to investigate what's happening. I mean, what is the underlying condition, especially in a 49-year-old patient. So this needs investigation. So you see the red flags are always start coming in, you know, that age. We need to look at what's happening. So they need to be referred to a gynae first to look at the underlying condition. At that age, we really don't expect those severe menstrual pains to have cropped in, yeah? So they need an underlying treatment. Treatment for chronic hepatic neuralgia. So this is more like a neuropathic pain, and most of the time we tend to start with probably carbamazepine before you move to, you know, the other newer neuropathic drugs, pregabalin or gabapentin. So this is stepwise approach. Use the stepwise approach in treatment. Are opiates safe in pregnancy? Post, once delivered, yes, they are very safe, yeah. But remember, opiates have respiratory depression. So during the pregnancy period, no, they're not the first drug of choice in pregnancy. In pregnancy, as I said, the safest analgesics is paracetamol, unless it's a very severe pain, which now needs investigation. Back to you, Hezron. Thank you very much.
All right. Thank you so much, Dr. Okiko, for tackling those questions. I believe those who've been asking the questions are satisfied with the responses. I think for Square, I'm seeing there was a question with regards to visiting of the facility. Maybe, I don't know if it's Elvin who can give a response on that.
Yes. Good evening, everyone, and thank you for the wonderful presentation, Dr. Okiko and Hezron, for the articulate moderation. Yes, we do organize and arrange and facilitate some plant visits by you as the healthcare providers, that is the pharmacists who are the giver of our brands to the end users. So only that it has to be pre-arranged prior. So yeah, it's something that we do with healthcare providers and also with pharmacists and pharmacy students. There was also another question on Trampa having a reduced dose of 37.5 milligrams paracetamol and tramadol and 325 mg paracetamol, which is lower than the usual dosage for the independent molecules. So I think I'll also tackle that. Because the benefit of this combination, the multimodal analgesia, it is designed for safety and efficacy. So paracetamol being 325 mg is very well below the daily toxic threshold, and the tramadol 37.5 avoids the limitations of the opioid analgesic as a class effect, like the seizures, respiratory depression, disturbances to the GI system. So now you're able to achieve a safety with Trampa, and also the flexibility in dosing to allow for multiple dosing throughout the day without exceeding the safety limits. So that is why Trampa has the lower strengths of the individual molecules. Also, with the synergy of the multimodal analgesia, you're able to have optimum fine-tuned pain management and analgesia effects at those strengths of the individual molecules. Thank you. Unless there's any other to square.
I think that's all for now. And I'm sure if there are going to be any questions, we'll be able to address them during the conference as well. So I think we've come to the end of the session, and I'd just like to welcome the Square team to just give some 1 minute just to hear your voice. Can have Shad, then Rinton, maybe you can say something.
Yeah, thank you so much, Dr. Harrison, for your wonderful, also the anchoring of the program. You know, mine is very brief. It has been really a great evening for us, especially. We really wish to thank Pharmaceutical Society of Kenya for the opportunity, as well as acknowledging the partnership that is Square that we have been really offering to PSK. You know, being one of the largest associations in the medical fraternity of Kenya, one thing I really confidently can say that PSK arranges the program which is highly participated, whether it is online or offline. In fact, I am also really happy to see over 1,000 doctors have joined today in today's session. Of course, it shows the commitment that you people has to your profession, of course, to your service. Yeah. I believe that you have heard Square from my colleagues' presentations, the mission that Square has in Kenya. You know, being the leader of Bangladesh pharma market, having that experience since from 1958 in manufacturing, of course, in the leadership, driving wheel since from 1985, coming across to have all those approval from the regulated authorities like US FDA, UKMH, or TG Australia. You could see the journey up to Kenya. Not only that, having product exporting to 47 different countries throughout the world, considering all the continents. You know, the journey to Kenya, it's the very unique one. What Square has observed as not only the country Kenya at large, the East Africa has really been suffering in pharmaceutical supplies, really depending on importation of pharmaceuticals product, where 85% of our requirements goes to the importation. So if you look at the total pharma market, when it stands to be at 1.2 billion US dollars, you know, 85% means almost 800 million US dollars we have been really sending away. So the mission Square has taken, it is to have that quality, affordable pharmaceuticals technologies transferred to Kenya. You can see from my colleague's presentation, it already in place. We have started the journey in 2018. Of course, we came into the operation in 2022, December. We have almost 30 products in the market, which already coming from our EPZ plant. The one simple statistics will really make you happy to understand that, you know, that 1.2 billion US dollars market, where you could see 85% which is being imported. You know, in our last year operations from our manufacturing plant, we produced pharmaceuticals products worth 3 million US dollars. It is very small number to 1.2 billion US dollars, but yet the attempt has already been made. You could see the progress that we have made in generating numbers, meaning that $3 million which used to be sent to Bangladesh, now it is contributing to our Kenyan pharmaceuticals industry at large in the economy of our country. So what is our kind request to the association at large, all the members of the society? I think it is now our time to look into what we can do for this industry which has come to the country with that such pharmaceuticals technologies to boost our local manufacturing, especially to have quality, affordable, international standard pharmaceuticals product locally manufactured, so that we may make the journey possible, which is in our dream, to have the pharmaceuticals product sufficiently manufactured in Kenya. So we have the inbuilt slogan, what you say, in Kenya for Africa. We are not only focusing on Kenyan pharma market, especially to fortify the manufacturing of East Africa at large, Africa. We sincerely appreciate all of your times, and we believe our partnership would be continued, and we shall make the journey really a successful one, not only for Square, not only for PSK, of course, at large for our industry in Kenya. Thank you so much. Asante ni sana. We shall meet again.
Right. Thank you so much, Shao. I think next we'll have Rinton.
Good evening. Thank you, Dr. Herjan, for excellent teamwork. First of all, I'd like to thank you for PSK team members, the management, including CEO Dr. Ivy, who took the initiatives to come to our office, had the meeting, and taken the initiatives. And this is the first time we are partnering with PSK in bigger way. We are partnering for long, but this time we are partnering for bigger way. As initially it was mentioned, this time we are planning to have more than 800 pieces of polo shirts for PSK during the conference, and that will be coming from Bangladesh from Square own factory. You have seen Square has 27 sister companies, where textile is also leading in Bangladesh. We supplied this textile to big brands, Adidas, Puma, Hugo Boss, all those. So we are bringing those t-shirts for you. So we wish all of you will be joining the PSK conference that's happening next month at Mombasa. We will be having our stand there. Kindly visit there. And as you are aware, already we have set up our plant in Kenya. One thing I want to mention in Bangladesh, also to inform you that I am also a pharmacist, but I work in pharmaceuticals company in marketing. Bangladesh, our pharmacists are very much aggressive working in pharmaceuticals company because that is a very good career growth. But Kenya, it's not present that level because we have only few pharmaceuticals company who are manufacturing the products locally here. So there will be good opportunity for our pharmacists in Kenya to work in pharmaceutical sector. Already we have quite good number who are working in our plant. Gradually, we will be having pharmacists in the marketing sector also. So it's a great partnership together. You will have your career growth also in this sector. And regarding plant visit, we are already arranging different pharmacists from big hospitals already visited the plant. So gradually we'll be communicating with PSK to have the numbers and we prioritize the visit accordingly. So we have more than 160 product kindly registered in Kenya, and already 23 products are coming from this plant in Kenya. Another 4 products we also launched this year, that is including boriconazole, most expensive product in the country. You can see what is produced in the country. We have already introduced for this product from Kenya, so that will be most affordable and available at your service. Also, we introduced MJAT, empagliflozin, and combination with metformin. You have seen our other portfolio too. So whenever you get the opportunity, kindly support us. Square, being the local manufacturing facilities, our objective and our slogan that build Kenya by Kenya. So that will be the motto. As you work, different hospital, different chemist, different places, including PPB, we get support from there. So kindly support Square so that we can grow together in this country, and we support more to PSK. We wish to have more webinars and physical CMEs too with the PSK in coming days. our partnership will be continuing as we started. Thank you all.
All right, thank you so much, Rinton, for that insight. And we're very glad to have you and also the support that the Square team has given us. It was a pleasure planning for this. Elvin, Kenna, Rinton, and Mr. Shah. I think we're really looking forward to the conference and also just having our members see the work that you do by organizing the visit to Square. So at this point, I'd like to just take you through the final announcements for the session before we close. And just as a reminder, the dates for the conference is 18th to 20th, and it will be happening at White Sands. So end of this month is when we'll be having the tickets for the late bird ending. So ensure that you book in advance so that you enjoy the discount. And like you've heard, Square is our polo shirt sponsor. So if you come to the conference, be sure that you'll be able to get a t-shirt, a polo shirt that is courtesy of Square Pharmaceuticals. This Thursday, we'll be having a webinar in partnership with MEDS, which is on building a resilient health supply chain for the health commodity security. So ensure that you mark your calendars for that webinar. And then finally, from the Pharmacy and Poisons Board, you're reminded that when reporting all adverse effects and poor quality health products, you're required to use 3 ways. And the first one is the website, where you can visit pv.pharmacyboardkenya.org. And the other option is through the MPVAS app, which you can download from the Google Play or Apple Store. These 2 are for the healthcare professionals. And finally, for the public, they can use the USSD code *271#. And once again, thank you to our speaker, Dr. Okiko, for that presentation. We look forward to having more presentations. And to the Square team, the entire team, we really appreciate for the support and also for sponsoring this session and the conference. Have a good evening and see you this Thursday.
Thank you. Good night. Yeah.
Thank you. Good night.